Good morning, everyone. Thank you so much for being here. I think we can leave the door open for now in case anyone else is joining. I'm very glad that I can be here today moderating the panel, which is titled European AI-Powered Solutions to Combat Dementia, How to Implement AI in the Health Sector. The purpose of this panel is to explore the legal, ethical, and some of the technical considerations of the applicable EU legal framework. So we'll be looking at the GDPR, the EHDS, and AI Act, as well as several others if we have the time. So if you've been here at the panel before, I think it would be really nice to continue that discussion with like a little bit of a topic twist, let's say. My name is Klaudia Kwiatkowska. I am a research associate, a PhD candidate at the University of Vienna at the Department of Innovation and Digitalization in Law. And as the name of the department says, we do look at a lot of questions on the bridge between law and technology. So how does innovation impact law, but also how does law shape technology? And as a research associate, I have been involved in some research projects, mostly relating to health and technology. And one of them I want to mention today because it sort of inspired the topic of the panel. eBrain Health is an EU-funded research project which aims to deliver a research platform for modeling and simulating the complex neurobiological phenomena of the human brain, and do so in a data protection compliant environment. The project aims to enable better research and treatment of dementia, while at the same time not compromising on data privacy or data quality. And just to give you an indication of the significance of this kind of research, dementia affects over 50 million people worldwide, which is a number that is expected to rise by up to 82 million by 2030. One of our speakers today will also talk a bit more about how to involve people living with dementia in policymaking and how to ensure that they have a voice as stakeholders. And of course, when talking about brain research and neuroscience and well-being at CPDP, it's impossible not to mention the topic of artificial intelligence. AI is particularly useful in neuroscience because the data-driven AI models can analyze complex data sets and help researchers and healthcare practitioners in diagnosing, treating, and preventing different brain diseases. However, inaccuracies and biases in the data and in the AI algorithms may also result in biased and negative outcomes for health, such as a wrong diagnosis. And while the AI models train on large amounts of data, including sensitive data relating to health, they can also be really useful for research. And in order to be useful for that, they need to be accessible and discoverable for researchers. So from a legal regulatory perspective, there is a lot of legislation to look at. We, of course, have the GDPR, which regulates the processing of personal data, but then the new AI Act, which will soon deal specifically with AI issues, and the whole European Data Strategy, which encompasses the Data Act, Data Governance Act, and last but not least, the European Health Data Space. And in the next hour or so, I hope that our speakers will be able to shed some light on these important considerations, and we'll have an opportunity to discuss also with you what those legal acts mean for dementia research and more generally for AI in healthcare. And now, before we begin and I give the floor to the speakers, some formalities, I would like to note that our panel is funded by the eBrain Health Project, which receives EU funding. However, disclaimer here, the opinions presented here today do not necessarily reflect those of the EU. And we will have the presentations from our panelists right now, and afterwards I will immediately open the floor to discussions and questions from you. So the way we will move forward, I will introduce our first speaker and give them the floor, and then the second one, and so on. So with that, I have the pleasure to introduce Petra Retta. She is Professor of Brain Simulation, Head of the Brain Simulation Research Group at the Berlin Institute of Health, at Charité University Hospital in Berlin and head of Charité's Department of Neurology and Experimental Neurology. She leads and coordinates several international neuroscience projects. She's also the coordinator of eBrain Health and will tell us a bit more about her work and the challenges. You can.
Oh, I speak for that. Okay.
Sorry. Yeah, but you can also turn. Yeah.
Okay, that's better. Yeah. So thanks, Claudia, for the nice introduction and for organizing this important panel. And it's nice to see that there's a quite high interest in the topic. So I will focus in my presentation today on solutions, infrastructure solutions for compliant management of health data and AI applications. And in the first slide, you see a digital twin of a brain. Yeah? And this is my field of research. We are building digital brain twins and simulate them on high-performance computers. And in a way, these applications are also defined as artificial intelligence. Yeah? They fall under the new Artificial Intelligence Act. And many requirements need to be fulfilled in order to be compliant, including GDPR, General Data Protection Regulation, that came in force in 2018. I forgot now to start my stopwatch. I do it now for only 7 minutes. In the project that was introduced by Claudia, we are developing such infrastructure to enable research on complex data, such as brain data, complex simulations using high-performance computing and cloud computing in compliance with the law. And Europe, and also Germany, the country where I am from, is aiming to spearhead the development of trustworthy AI. And with the AI Act being now soon in force, so I think it comes in force in June when it's published in the official journal of the European Commission, but it has passed all other steps already. We have worldwide the first legal framework for making AI trustworthy. But part of the trustworthiness is also GDPR compliance. Yeah, there are different facets that are covered by the AI Act, and one is data privacy, also cybersecurity. We have worked already in the past for many years, initially in the context of the European Open Science Cloud, now in the context of the project of eBrain Health, and also other projects where we are involved with, like the Human Brain Project and eBrain's platform, which is a research infrastructure on the S3 roadmap, the European Strategy Forum for Research Infrastructures. It's a sustainable European platform. For this platform, we are developing the Health Data Cloud. And this comes with all the technical and organizational requirements that are needed in order to be compliant with the law. So there are really quite big challenges. Also, what is very important to be compliant, we are not, as a platform operator and provider, taking control of the data, but we make sure that the solution enables the controllers of the data to stay in control and full control of their data. And this is also in compliance with GDPR. So this is how one such node from the previous slide looks like. There's a lot of functionality included in order to make this cloud resource useful for researchers. I mentioned already that in many cases, high-performance computing backends are required, and also they need to be GDPR compliant and certified. I show you in a moment what that requires. But there are many other functionalities. So, for example, of course, access control, authentication, but also logging of all the activities. We also provide tools for verification of data, for annotation, for versioning. This is a scalable cloud solution, so the number of users can increase with time, and also the usage of the resources. And the users have the possibility to, for example, bring in their own software as desktop applications. So they have a remote desktop to work with their data as they would do this on their own computer, but remotely in a secure, isolated environment. All the projects are isolated, so there's no possibility for unauthorized access of data. But it's not just the technical solution, it's of course also the organizational principles that matter. What you see here are the software components that are part of this cloud health data cloud solution. There are many open source components, so the entire cloud is based on open source, and this is one of the principles of the Digital Europe program and the Digital Europe regulation to favor open source solutions, because this also brings a lot of benefit. It brings transparency, but also the possibility to early on detect, for example, security deficits and to provide patches for those. We have a full automation of this infrastructure, so when there are updates of software components, they can be included, which is also one of the security mechanisms. And here I showed just a couple of the technical security measures. I do not have time to go in the details, but one important component is that the infrastructure, the data center, is certified for information security. So it's a critical infrastructure, it follows certain standards and undergoes regular biannual or every 2 years, I should say, the certification and recertification. Here you see, you don't need to read it, but you see the organizational principles. They are mapped on the law, the legal principles. So there's always an assessment of the legal basis for providing access to the data. There's a definition of the roles, like processor or data controller. There's a risk evaluation. There's a consultation with the relevant DPOs. There's a consultation, if it is a high risk initially, with a supervisory authority. And only after these steps has been passed, which are part of the law and cannot circumvent it and shall not be circumvented, the actual processing activity can take place in this cloud solution. And in order to certify this GDPR compliance, we initially had external audits by law firms, but now, since the end of last year, there's this Euro privacy seal available that is endorsed by the Euro Data Protection Board, and we went through the Euro privacy certification preparation. It's only now that the first company has been accredited to do the actual certification, and we just start this process. So this is something very new, but it is helpful because this then provides a seal, a label for GDPR compliance. The infrastructure can be accessed via the eBrains research platform. It can also be actually accessed via the European Open Science Cloud Marketplace, but if you're interested, you can just go to ebrains.eu, and there under health data you will get access to the documentation and the infrastructure itself. One important aspect is also discoverability, not only of data, but also the software, the pipelines that are included in the health data cloud and the actual web platform itself. So the tools and the data and the platform itself are annotated with metadata. In the context of eBrains, metadata models, schemas are being developed and can be discovered via a knowledge graph that is also accessible via ebrains.eu. So there you find all the data that are in the cloud, but also the software that is being developed that can run in the cloud, like containerized workflows. For the actual sharing of sensitive data, we use the standard contractual clauses that are recommended by the European Commission, and they are part of the datasets and pre-filled by the data controllers. So only the information of the potential processors will have to be added before the actual processing activity can take place. As I mentioned, the cloud infrastructure is complex, and you have different possibilities to work with the data. It's not just for storage. You can bring in containerized workflows, for example, and we have developed several, but users can develop their own containerized processing workflows and bring them in the infrastructure to process their data. Also, I mentioned already, there's remote desktop. There are remote desktop available, so you can also use and deploy software that runs on the desktop. The infrastructure now already is the health data infrastructure of several European projects. This is not an exhaustive list, but these are the most important ones. And they are, or the infrastructure is basis for several publications, also in the field of dementia. This is a publication where 650 virtual brains have been constructed from individual imaging data and simulated on the high-performance computing infrastructure of the health data cloud. And the principles of decision-making and differences in decision-making, the cognitive processes in these 650 individuals were simulated, and the mathematical background, neurophysiological background has been understood with these simulations. I'm coming to the end, but I want to also mention, and Claudia has already touched on this, it's not just about GDPR compliance, but such applications, if they're used for patients, for example, we use brain simulations for planning deep brain stimulation, and Parkinson patients need to be trustworthy, and there's much more to it to be trustworthy in the sense of the AI Act. I don't go through the different, oops, sorry, this was too fast. Anyways, I stay with the slide. You saw the different boxes where the different aspects of trustworthiness were mentioned. So this requires a lot of metrics, standards that need to be fulfilled, protocols to test these standards for trustworthiness, and the actual then evaluation reports. And in order to achieve this, so many parts of this are missing. The actual standards often do not yet exist. The test protocols do not exist. This all needs to be developed. And for this, we are leading at the Charité another big European Digital Europe project, which is called Testing and Experimentation Facility for Health, AI and Robotics. It develops infrastructure, access to services, physical testing services, virtual testing services like the Health Data Cloud to enable validation and certification of such complex AI technologies or digital twin technologies. And these services are available for industry. They are, of course, also available to academia, but they are made for industry. There's a business model that is being developed for this testing and experimentation facility, and this is also part of the AI Act. You will find these testing and experimentation facilities mentioned there, and they will exist also in the long term. And with this, I think I come to an end. I thank you very much. I was a little bit longer, sorry for that, and I hope we have a nice discussion later on. Thanks.
Thank you very much. Our next speaker is Ea Hebold-Haraldsen. She is head of the Cognitive Health Research Group at the Department of Neurology at the Oslo University Hospital. She is also the primary investigator of the AI Mind project, which integrates AI into the diagnosis and treatment of dementia.
Hello, everybody. It's a pleasure to be here, and it's a pleasure, Claudia, to have been invited. I'm so lucky that I'm representing both projects. In Petra, where AI Mind is responsible for the AI development within the eBrain Health project, and another large-scale European action is, in fact, the AI Mind project, which will be directly a use case in the eBrain Health project headed by Petra. Why is it important that we are a node, and why is dementia a field of artificial intelligence support? And Claudia asked me two questions: how can AI be used in dementia care, and what are the technical solutions at the moment? The objective is clearly that we as human beings are not good enough identifying dementia as early enough. Meaning, in the European countries, you need on average 5 to 8 years before you are finally diagnosing dementia, and it is too late, because when you are diagnosing, there is no cure and no help. Although there are developments at the moment from the pharmaceutical industry ongoing to offer mild cognitive impairment states some medication, these medications are not sufficient to solve the problem. In addition, 40%, and that is under-communicated, of all cases in dementia could be prevented if the citizens globally would have been informed early enough that they are at the risk zone. It's clearly that we need, with the global population development, that we need to prevent dementia, and we will not be economically able to treat dementia. We will not have money for police, schools, and other activities of our states, and recently also for the War Department and Defense Department. We do not have the money, meaning that we have to educate our citizens how they are personally able to prevent this disease. Another issue why these activities between eBrain Health and AI Mind are so important is that we need to come to personalized medicines. Until today, medical history is not individualized. It is in the head of a doctor, a group-based estimation. My experience as a medical doctor will lead to a diagnosis, to a probability how I consider that you may suffer from this or another disease. This will change with our technologies, and we will in fact move, as Petra mentioned that with the virtual brain, that we will went into a personalized hypothesis generating and treatment offers. That means also, and I wanted to remind the audience one more time, on AI is just like a human doctor's head. AI is group-based statistics, meaning it will be faster, it will be maybe as a support more accurate, but it will never be personalized. For being personalized and being really a next step into the revolutionary next era, we need this combination between simulation tools and AI tools. And that is what we are building by our infrastructures. What are now the challenges? It is obvious that none of these technologies exist today at a usual hospital. It is also clear already now that we will not generate enough data at single hospitals, single nations in the European Commission, and we will need synthetic data in addition. This is a field which is growing, but it is still in a huge lag of interdisciplinarity. And Petra mentioned the standardization is demanding and urgently needed. It is also clear that the national budgets of hospitals often have not prioritized computer resources and infrastructure which would make such technologies available. It is important, and it was a meeting just before this morning here on the other side in the aula, where it was stressed that European solutions have to be found to consolidate and to make the resources more available not intercontinentally, but inter-European. And for sure, we need to stop at once to invest into local infrastructures, only which would not be reachable from other sources, meaning like eBrain Health, we need to build federated infrastructures so that not all nations have to do the same program, but that we can have add-on values. A very difficult issue is the GDPR, because mainly ministries of defense and cybersecurity activists, I almost have said, would have said, are not integrated necessarily in health departments in planning infrastructures. This is a demand that you, from the beginning, if you are planning as a hospital or as a nation an infrastructure, you have to include other partners from other areas who know more or better about cybersecurity acts. And then, very last but not least, the trustworthiness, just as Petra also said, is always coming by being transparently describing what you are doing. And you have to emphasize documentation. This is in medicine, in fact, a problem. Documentation is almost counterproductive because the patient-doctor relationship is regarded as being an intimate, secret, not publishable dialogue. This is a contradiction to the needs we have if it comes to use and reuse of data. And we have to redefine the patient-doctor relationship. And this is just in this beginning to be problematized. It needs a kind of revision. It is no doubt that the next generation of deep learning models will fuse with into hybrids with simulation technologies. It will be hopefully a personalized medicine of the future, gives us the opportunity for the first time in history of medicine to really individualize our processes or our predictions. And it is very important that we do not forget that all models, all generative AI or whatever it would be, are always, like all kinds of thinking, are always characterized by uncertainties and limitations. And this is too little communicated within the society. AI will not be perfect. The doctor is not perfect. The combination can be better. Not more and not less, but it is important that the legal implementation of just these uncertainties and limitations are demanded for each model being described. For example, in a knowledge graph, you can number it and you can list which kind of limitation your system has. Thank you so much.
Thank you so much. And our next speaker, Daphne Lamirel, will continue the topic of trustworthiness and raising public awareness. Daphne is Public Involvement Officer at Alzheimer Europe. She works with people affected by dementia and other members of the general public on involving them in the research process and output of various projects. She also leads a patient advisory group in eBrain Health.
Thanks, Claudia. Hi, everyone. So Ira was talking about the importance of public awareness and trustworthiness when it comes to medical AI, and I think what I'll be talking about is quite a key activity that can help in this regard. So just a bit about dementia. We already mentioned it, but in general, dementia refers to an umbrella term that is used to describe lots of different symptoms, including problems with memory and thinking ability. There are many different types of dementia. So at Alzheimer Europe, we work, for example, with lots of people affected by Alzheimer's dementia, but also Lewy body, vascular dementia, frontotemporal dementia, and dementia symptoms vary according to the individual. Each situation is unique. What we're noticing now is that there is really an increasing movement of trying to speak to the people who are affected by dementia. And this really shows that there is more and more reduction in the stigma and also stereotypes associated with dementia. For example, the idea that people with dementia can't participate or voice their opinions about the topic. at Alzheimer Europe, we're involved in a range of research projects where we are involving people with dementia into the research project, different types of dementia, different stages, and the people are able to provide very useful opinions that can help with making the project more relevant to them and also more trustworthy to the public and people affected by the condition. So just a bit about Alzheimer Europe. So we are an umbrella organization of 41 national Alzheimer's associations from 36 European countries. Our mission is to change perceptions, policy and practice with regards to dementia. And we partner in lots of different research projects, including in e-brain health, where our role is to involve different members of the public that are affected by dementia in some way, such as people with dementia, with mild cognitive impairment, and carers. So I already talked about public involvement. This is also known sometimes as public and patient involvement, but basically this refers to the active involvement of members of the public into the research process. So it's not just about providing information to them or doing research on them, but really about getting their views on different aspects of the research to make that research more relevant and ethical. There's been quite a few studies showing that public involvement, or PPI, increases the quality of research and makes research more transparent and ethical, and it's now a requirement in many EU-funded projects. So regarding e-brain health, the public involvement in this project, I think, was quite challenging because the topic, as you probably heard from Petra and Ira, is quite complex. So to explain the project to people with cognitive issues was quite challenging. And one of our main tasks was to talk about ethical issues and get people's perspectives on ethical issues related to AI, which is also quite an abstract, complicated topic. But we set up an advisory group with different people from different European countries, people with dementia, people with MCI, people at high risk of dementia, and also some carers. And we held different consultations where we explained the project, the different issues. We also did some testing of certain apps that are developed within eBrain Health. And today I just wanted to give you a brief overview of the main concerns that came up with regards to what people think are important concerns that must be addressed when we're talking about health-related AI and the topic of digital brain twins. Sorry. So this is the advisory group. So one topic that came up, which I think is not totally surprising, is the issue of fears about technology. So when we presented the project, initially people were quite fearful when they hear the term digital brain twin. They maybe associated that with the idea of cloning or things like that. But then there was also the other side of the coin, where people were also very enthusiastic about having a model that is very representative of the brain, and they maybe saw the technology as something more advanced than it actually was. So this really emphasizes the importance of using the right terminology when we're communicating about digital brain twins to the public and AI more generally. The people with dementia were saying that brain twin might not be the best term, and it might be useful to also use terms such as a brain model or representation, something a bit more neutral that doesn't create any fears but also doesn't create any false expectations. And I think this applies to many other AI products where we use lots of human terms to describe the AI. Of course, another concern that comes up a lot when we're talking about AI in health is data privacy and confidentiality. So here are a few issues that people were talking about with regards to this. So in general, people were saying that they want to know how their data is being kept secure, how their privacy is being respected. So again, this shows how important it is to communicate about how this is being done within a project. And in the context of dementia in particular, people were expressing that there's still so much stigma and discrimination that this creates an additional barrier where people might be scared to share their data with a brain twin because of fear of being discriminated if there's a breach in data security, for example. Human contact is another big one that people talk a lot about. So, for example, they are scared that the AI might just focus on biological aspects or not take into account socio-economic, environmental variables. We mentioned bias and discrimination. People were less aware of this issue, but once we discussed it, they really mentioned that it's important to raise awareness about it and really communicate which data, for example, was used and what kinds of risks of bias are there within the model that is being used. And then from that point onwards, people can make an informed decision of whether or not they want their clinician, for example, to use the AI. So to conclude, AI and digital brain twins, as I mentioned, are a very complex and challenging topic to discuss and raise with the general public and people with dementia, but our experience really shows that it can be done in a meaningful way. There are lots of concerns that were raised, but people in general were also extremely positive about the use of AI and willing to use that in the clinic, for example, to improve their treatment, diagnostic, management of symptoms, etc.
Thank you so much. So now we're moving on to topics that are not less complex, because we'll be talking about the law. The next speaker, Lukas. Lukas Feynman is a research associate at the Department of Innovation and Digitalization in Law at the University of Vienna. He is involved in several health-related research projects where he deals with digitalization and data protection in medical research and the cybersecurity sector.
Thank you. Thank you very much for the kind introduction, Claudia, and all to the other panelists of very much and very, very nicely presenting what we're doing in the project. I have a very boring task now, I think. I have to try to explain how the law, the AI Act and the Medical Devices Regulation, and that's what we're trying to develop here is playing together. I think the project that we're working on is especially interesting for two reasons. On the one hand, because the technology, what we're developing is also, from my comparison and what I've worked on so far, I think incredibly advanced, incredibly interesting, but also incredibly complex. And on the other hand, I really appreciate the patient contact and public contact we have within the project, because it really makes it visible for whom you're developing all of these technologies and who will be affected in the end. Okay, basically for this very legal exercise now, I have made two assumptions. On the one hand, we're assuming that these digital brain technologies, digital twin technologies are coming on the market at a certain place. And on the second assumption is basically that the AI Act as it stands now will be enforced then. So we're basically looking how does our technology fit within that regulatory framework. And I will come up with a pyramid that you have probably most likely seen already quite often, namely the risk classifications within the AI Act. Just maybe to sum it up a little bit, we do have within this regulatory framework, we do have 4 risk classes. The harshest and biggest one is the unacceptable risk in Article 5. That's basically certain use cases for artificial intelligence where our society, where our lawmakers are saying, we don't want to have that. We don't want to have AI used in any of these situations. Transparent example for is social scoring that is sometimes used in Asian countries at the moment, and there's a very clear prohibition of these use cases. Then we have the second class, which is the so-called high-risk classifications and use cases, where you have quite extensive requirement on the one hand side for the design of the system. but also have quite extensive requirements for the obligations for providers and also users of these AI systems. And if you just look at the text or the amount of text actually within the AI Act, you will definitely find that most provisions are actually targeted towards this risk categorization. So basically, the high risk class is a class that is still doable, but comes with a lot of requirements. Especially the most important one probably is you have to undergo a conformity assessment. The third risk class is the limited risk class, where you do have like certain transparency obligations. For example, you have to, that's in Article 52, for example, you have to state and make it visible for the user that they're interacting with an AI system in any form. So it's more of a labeling obligation in that sense. And the fourth risk class, which isn't a risk class at all, because we said we don't have any regulation on that, is the minimal risk class at the very end. And maybe to make a deep dive in Article 6, Article 6 basically provides for requirements when a certain product has to be classified as such. It's actually a quite complicated paragraph. I tried to summarize it for you a little bit here on the side. What you first of all need, you need some form of product. Yeah? A software application such as digital brain twins also will count towards, will classify and will qualify as a product. And second, you need to have a specific legislation that is listed in Annex 2 of the AI Act. And as a third requirement, based on this legislation, which is listed in Annex 2, this specific product has to undergo a specific conformity assessment. And if you take a deep dive now in Annex 2, you will see that under point 11, you do have a regulation listed there, namely the regulation of the EU 2017-745 of the European Parliament, so on and so forth, which is basically the medical devices regulation, which regulates the implementation into the market and also the sale of products that are used for human treatment and diagnosis. Yes. Here you have it even nicer. This regulation lays down rules concerning the placing on the market, making available on the market, or putting into service of medical devices for human use, and also accessories of such. Okay, so when we go back to basically our applicability test in Article 6, we know we do have a product already. We are probably subject to a listed legislation, namely the medical devices regulation. Now we have to ask the question, according to this specific regulation, do we have to undergo a conformity assessment? Yes. Exactly. Do we have to undergo a conformity assessment? We do have also risk classifications in the medical devices regulation. We do have a class 1 here, which is considered to be low risk. We do have two medium, mediocre risk classifications, class 2A and 2B. And we also have, again, a very high risk classification. From class 2A to class 3, we have to undergo a conformity assessment. All of these classifications criteria, yeah, okay, that's not working as intended, but okay. Based on this classification criteria, you will actually find certain rules also in Annex 8 of that specific regulation. You have, for example, then in Annex 8, a Rule 11, which states, for example, that software, when it's used as a diagnostic tool or therapeutic for therapeutic purposes, you can classify that as a risk class 2A, except if it's used for even more harsh cases where the use can, for example, lead to death, irreversible deterioration of a person's state of health, and so on and so forth. If you don't use software for diagnosis or therapeutic purposes, then you can classify it as class 1. Going back to our checklist again, We assume actually that we will probably use our digital brain twins as a for diagnosis and therapeutic purposes. So we'll probably also be likely to have to go on a conformity assessment. All of the conditions of the Article 6 then in the AI Act is fulfilled, which in the end means that we also have to go and undergo a conformity assessment based on that regulation. What I wanted to try to show you with that, I think it's actually in theory and practice not so easy to determine, and it's quite actually a legal challenge on how you're actually coming to applicability of that act. And I hope that your use case made that a little bit clearer. Thank you.
Thank you so much for that. And last but not least, we have Richard Rack. Richard is manager for digital health policy at Digital Europe and a research fellow at the University of Milan. His expertise lies in digital health law with a focus on privacy, data protection, and data governance challenges relating to the establishment of the European health data space. And he is here today to talk a bit more about that.
Thank you very much, Claudia. Good morning, everybody. So I would like to present you the implications of the European health data space for AI innovation in dementia research. One of the main objectives of the EHDS is to scale up the use of the secondary use of electronic health data. However, as the legislative procedure had to be rushed in order to complete to reach a compromise before the election, we now have skeletons in the cupboard that will haunt us in the coming years. So I will try to pinpoint those provisions where implementation will be key and where stakeholders will have a role to coordinate and also provide feedback to the Commission and Member States. Just in case you are unfamiliar with the data governance framework for secondary use of electronic health data in the EHDS, then here I've sketched how this will look like, the general scheme. In blue, I've indicated the three main actors: the health data holder, the health data access body established by member states, and the health data user. The idea is that if we move from the bottom left-hand corner, that health data holders processing personal or holding non-personal electronic health data will have to make available dataset descriptions in national and EU dataset catalogs. The health data users will be able to look up which datasets they would like to have applied to have access to, and if the health data access body grants a data permit to the health data users, then they will be able to access those electronic health data in secure processing environments in either anonymized or pseudonymized format. And there will be also an option to access electronic health data in anonymized statistical format pursuant to an access to a health data request. And then following access in the secure processing environment, the health data users will have to publish their results or output. There will be also an additional avenue to access electronic health data directly from so-called trusted health data holders, which will be designated by member states, so such as large hospitals who will have the infrastructure. Now, what does this mean for AI innovation in dementia research? I want to highlight 6 challenges: the definition of electronic health data, the sources of data for secondary use, the secondary use purposes, the opt-out mechanism for patients, what this would mean in terms of IP protection for researchers and innovators, and the implications of using such secure processing environments. The definition of electronic health data will constitute, on one hand, personal electronic health data, on the other hand, non-personal electronic health data. Here, in general, we see that these definitions are rather vague. The definition of personal electronic health data will link to the definitions of data concerning health and genetic data in the GDPR. However, we already see that there are challenges in how to interpret the scope of these data. For instance, in the case of genetic data, it may not only refer to certain data subjects, but also to a biological family of the data subject or even future generations. The EHDS does not clarify these links. Even more problematic is the definition of non-personal electronic health data, which will be somewhere between personal electronic health data and non-personal data. Here, in the rush of the trilogues process, we have a very broad definition, which will cause problems throughout the legislation, as it will not be clear when does non-personal data become related to health. So when does it fall within the scope of non-personal electronic health data? In addition to the vague definitions, such as the definition of electronic health data, stakeholders have criticized the data categories for secondary use. Everybody recognizes that the EHDS will provide huge opportunities to integrate data from various sources. So in the case of dementia research, it will open up huge opportunities by enabling the secondary use of omics data, for instance, or data on factors impacting on health. However, certain data categories are unspecified. There's inconsistency also in terms of how this provision refers to the specific data categories. In the first sentence, it refers to electronic data. Then if we look throughout, sometimes it's data, automatically generated personal electronic health data, other health data, and so on. And this inconsistency will cause challenges for health data holders, such as those who have already developed an AI system for dementia use cases, or other medical device manufacturers, researchers, pharmaceutical companies, and so on, because they will not exactly know what data they have to make available, and this will also pose risks to them. In terms of the use purposes, again, the EHDS would facilitate the scalability of the use of electronic health data for secondary use purposes. It would enable scientific research for health-related purposes, including the training, testing, and evaluating of algorithms, including AI systems. So there's a clear legal basis to use electronic health data to develop AI systems for dementia research. However, the cumulative criteria for obtaining data permit or answer to a health data request will be up for interpretation by the health data access bodies, because as mentioned, data protection concepts are used inconsistently. There are references in the EHDS to certain ethical requirements pursuant to national law, but these are not clarified appropriately. Which are these ethical provisions that may come into play when the health data access body assesses a data access application? There may be also lack of clarity in terms of how these legal bases under the EHDS will interact with Article 10, Paragraph 5 of the AI Act, which enables an additional legal basis for bias detection and correction on top of Articles 6 and 9 of the GDPR. Then in terms of the opt-out mechanism, this was in the center of the political fight throughout the legislative procedure. Eventually, the co-legislators agreed to include an opt-out mechanism, that is to say that natural persons shall have the right to opt out from secondary use of personal electronic health data concerning them. However, member states will have the discretionary power to override opt-out for public interest purposes. If from a research point of view, however, this may be problematic because there may be scientific considerations when it's important to ensure that data sets do not include data bias or data disparities. So there's been an argument between data activists and healthcare researchers over that the opt-out to protect the right to data protection would be in conflict with the scientific interest to have representative data sets for research and, for instance, the development of an AI system. There's also a possibility that member states may introduce stricter measures, opt-in mechanism for certain data categories, such as the secondary use of omics data or data from biobanks. For what does this mean for researchers and innovators? The EHDS will require electronic health data that is subject to IP rights, trade secrets, or regulatory data protection to be made available for secondary use purposes. This may be in conflict with international IP treaties, constitutional laws, or the Data Act. Because, of course, if somebody invests millions of euros, years of research and innovation, and they have to make available their proprietary algorithms, then this may disincentivize them from doing research, or it may shift them to place their products, such as an innovative AI system for dementia use cases, first on the market in the US. And this is already happening, this trend. Health data access bodies will be responsible to take all specific appropriate and proportionate measures to protect such data sets. However, the worry of researchers and innovators is that health data access bodies may not have the resources and competence to fully understand how to protect such data sets and the underlying value. So it will be very important that member states will invest in the development of health data access bodies and upskilling of professionals who will be involved in these processes. And finally, secure processing environment. The output following access to electronic health data for secondary use purposes may be questionable in terms of their usefulness for AI innovation, because health data users will only be able to download non-personal electronic health data. But in certain cases, it would be useful to have access and use further pseudonymized electronic health data. So we'll see what this will entail in terms of the practical implementation. And so to conclude, for the EHDS to be useful with respect to AI innovation in dementia research, implementation will require, as mentioned, enhanced coordination and guidance by the Commission and Member States. I would encourage all health stakeholders to be actively involved in providing feedback. It will require adequate resources at all levels to support health professionals in understanding their rights and obligations, to facilitate digital health literacy of patients, to support the establishment of health data access bodies, and so on. Health procurers, I should also mention, will need to understand what are the potential benefits as well. And we need, the EHDS will apply these, the secondary use data governance framework for 4 years from now, more or less. So there will be, it's important to have some flexibility for legislative fine-tuning in order to take those skeletons out of the cupboard and to have legal clarity and consistency that will ensure that it will be useful for AI innovation in dementia research. So thank you for your attention.
Thank you so much. And we do have still enough time to open the floor for discussion. Are there any questions? Yeah, one question there.
Yeah. Thank you very much for your comment and your kind words. So first of all, I fully agree that it is important that the researchers in the public sector, but also in the private sector, have access to such data. Yeah? This is needed. Otherwise, it is impossible to do the kind of innovation and research that is required. And it is legally also foreseen. But this also requires shared responsibility. So the people who process the data, who get access, carry some degree of responsibility. They have to act in compliance with the law. And there I see a problem that the education is often not sufficient. Yeah? And this needs to be changed. I think that the UK has a very good model because they have centralized trainings for individuals who work with personal or health data. They have also centralized registry where the certification of such trainings, different levels of trainings, is monitored and stored, and such certification can be also cancelled if some activity is not in compliance with the regulation. This is required, and there I see from our perspective as an infrastructure provider the biggest challenge presently. The researchers often are not aware of actually the rules, yeah, and their responsibilities, and it's really difficult to educate them. I think it needs to be more organized and structured. But to your question, if I understood you correctly, whether there were breaches already, there were breaches before GDPR, especially, but also in the US. Also in Europe, related to the PACS, radiologic PACS systems, to just give you one example. These are systems that are used to store radiological data in the research and also the clinical setting. And they were not secure, and millions of data sets have been leaking out and are still partially available. Yeah? And this was actually very prominent in the media. You might have heard about this. So such cases happen. It's very rare. And therefore, for example, in Europe, there are no proper insurances because presently there were no relevant legal actions. Yeah? But this will change. GDPR is relatively young, and the legal actions will come as well. And therefore, it's important to have not just the organizational and technical measures in place, but also to have the insurances for the institutions for the case they are getting sued. As you will know, there's never a full, there will be always a residual risk of data leakage, and therefore such insurances are highly relevant. But I see Ira moving around.
Yes, because the biggest danger is coming from inside. You had on your continent the last really big leak, and that as I mentioned before, it is obviously necessary that the ministries of defense are included in our healthcare planning. And it is also clear that your continent have already tried to invade our data banks, which we are not happy about. So it is also between so-called friends that we have to look into detailed how much the European Union has to take care of their sovereignty.
Yeah, Lucas?
Maybe to make a very short legal argument about that, I think that the GDPR actually provides with certain provisions on what you have to do when such a data breach happens. I think it's one of the better provisions in the GDPR and one of the clearer ones. Basically, the idea is if you do have a substantial data breach, you have to reach out to a national, your competent data protection authority, and they go through steps with you on what to do next. That usually involves informing the data subject which data sets were in some form touched. I don't know if, I know, for example, in Austria, we had quite a huge case of data breaches from COVID testing laboratories. Yeah, exactly. Thank you.
Thank you. Are there any other questions or points? Yes. Oh, we have a mic.
I would like to elaborate. I'm Jarek Reser from VUB, and I'd like to elaborate on the cybersecurity issue, like following it, because we talked a lot about using AI in medical sector, and as all you know, we have specific cybersecurity issues concerning AI, like adversarial attack or data poisoning attack. And my question is, and especially from the industry point or hospital point of view, do you take into those problems right now into consideration? Do you have risk assessment on it? But I'm not talking about data breaching, but specific issues regarding AI cybersecurity.
Yeah, actually, cybersecurity in the context of AI is part of the AI Act. Yeah, so there are different categories that relate to the data privacy, cybersecurity, and the actual AI model. And cybersecurity is a risk that needs to be addressed. So there needs to be a documentation of the initial risk, the measures taken, and also an assessment of the residual risks. This is part actually already of the medical device regulation, but now also of the AI Act. Yeah, and it's being taken into account.
Yeah, I know, but my question is, AI Act is still not enforced, but do you take in consideration right now?
Yeah, sorry, just one. Absolutely. So cybersecurity is, of course, also relevant to GDPR. Yeah, you have to have the technical measures for high information security. So, for example, the GDPR compliance requires information security at a certain standard, like ISO 27001 or critical infrastructure certification in Germany via the BSI. And on top, you have the organizational measures that are relevant for privacy. So you have a high level of information security, plus on top additional measures to guarantee the privacy of the data. Sorry.
If I understood you correctly, you are also asking for security measures regarding the AI development in itself. And it's not only about the data security, it's also about the AI algorithm security. And this is complicated. At the moment, you know, most of the European development is located physically in Ireland and Facebook's resources. With regard to the AI development in AI Mind, because it will be a medical device class 2B, and they will be developed in own sandbox infrastructure, closed infrastructure, not accessible. But again, I underlined the big leakages recently came from inside and not outside. And that is, of course, a problem. Again, you have to monitor and you have to make log files and so on, who logged into the environment at what time point and so on and so on.
We just add, so you might have heard also about the AI factories, a new measure of the European Commission to foster the development of AI algorithms. And there, in particular, supercomputing centers in Europe are being addressed. And the testing and experimentation facilities, including the one for health, AI, and robotics that we are leading at the Charité, they are foreseen in the AI Act. You can read it there. To provide the facilities to validate and certify the compliance with the AI Act, including cybersecurity. Yeah? So this is an integral part of trustworthy AI and is being assessed.
Thank you. So we do have 5 minutes left, so there will be time for like one last short question if anyone has. Yes, we have one.
So thank you very much for a great panel. I've got a question which is probably mostly for either Richard or Lucas. And I'm Ruth Boardman, I should say, from Bird and Bird in London. We heard about the European health data space, and the provisions designed to facilitate secondary use of data, including potentially clinical trial data. Richard, you listed problem areas that you thought needed to be worked through. I'd be interested to know if you have an answer to how this fits with the clinical trial regulation, because the EHDS seems to facilitate secondary use of pseudonymous data for a range of public interest purposes. But how do you reconcile that with the concept that under the CTR, further use, if not anonymous, has to be in line with the ethical consent given by the patient?
I followed closely the drafting of this provision under the EHDS, and at first it wasn't even specified whether such data, especially from preclinical data, would have to be made available or not. Eventually, that will require publication of results, so that assures protection for researchers in the preclinical phase. Then in terms of making available data from clinical trials or clinical investigations, because for long this wasn't clear for co-legislators that the two are different notions. One concerns the development of medicinal products and the other medical devices. They can be made available as soon as the clinical trials or clinical investigations have ended, which is, of course, a significant risk, because the sponsors of clinical trials or researchers will not be able to file an application for patent. It may take several years after a clinical trial ends to have to file a patent or to have protection granted by the regulatory data protection right under the relevant legislations. The only protection is granted by the trade secrets. So if a researcher or a clinical trial sponsor is able to demonstrate to the Health Data Access Body, and more importantly, the Health Data Access Body accepts this legal argument, then those datasets will not be made available for secondary use purposes. However, this is going to be a crucial question that health data access bodies will have a consistent interpretation of these scenarios. And then another issue is then when it's made available, then the Health Data Access Body has to implement appropriate legal, technical, and organizational measures. And the health data holders, such as a clinical trial sponsor, researcher, will be able to conclude a data sharing agreement with the health data user. The Commission will develop some model template for this, but it's still an open question what exactly these data sharing agreements will entail. And so this is a very practical, and thank you for asking this question, a very practical issue where it's important to provide feedback or suggestions on what are the specific issues that need to be and data sets and how they need to be protected when health data access bodies issue a data permit for electronic health data from clinical trials or clinical investigations. And unfortunately, at the very end of the drafting process, the co-legislators deleted that data from clinical trials have to be made available subject to transparency obligations under the clinical trials regulation. And it's only included in one of the recitals of the EHDS. So perhaps that can support the linkage between the EHDS and the protection granted by the clinical trials regulation, but it's not in the binding text, unfortunately. So again, it's one of those points that could have been legislated in a better way.
Thank you so much. We are at the end of our time, unfortunately. Thank you to all the panelists again for your great presentations. Thank you all for being here. And if you have any additional points or questions, I'm sure we can discuss them over coffee or something. Thank you so much.